This is a discussion about cardiomyopathy, followed which we're going to talk a little bit about tumors. So first of all, with cardiomyopathy, we have dilated cardiomyopathy. In the case of dilated cardiomyopathy, this is where all four chambers of the heart have become dilated, which means they got bigger. This is the most common kind of cardiomyopathy. The result of dilated cardiomyopathy is that there is something called a systolic dysfunction, meaning that during systole, there is a dysfunction that occurs. Essentially, the mitral and tricuspid valves result in having regurgitation, and you also get arrhythmia. Let me explain a little bit about how this happens. So here's the heart. Right atrium, left atrium. Right ventricle, left ventricle. Okay, now between here, so right here is a valve, and right here is a valve. Now if this whole thing gets bigger, this is kind of what happens. So here's the valve, right? Now the heart's getting bigger. So when it opens, but when it goes to close, it doesn't touch. The whole heart's bigger. It was like this, dilated cardiomyopathy, dilated, and so now it regurgitates blood back up into the atrium every time the ventricles contract. So during systole, when the ventricles contract, there's a systolic dysfunction that results in both the tricuspid and the mitral valves. This valve right here is the tricuspid valve, and this valve is the mitral valve. Both of them cannot touch each other because they've dilated, and now there's a regurgitation that occurs, which means blood's gurgling back up into the atria during systole. This can lead to biventricular CHF, congestive heart failure. The causes, it says it's idiopathic, but some things that they have listed here are a gene mutation, also myocarditis. We know myocarditis can be caused by the Coxsackie virus. So the Coxsackie virus infection can be associated with dilated cardiomyopathy. Alcohol abuse, drugs such as doxorubicin and cocaine can result in this, as well as pregnancy. The only treatment for this is a heart transplant. Okay, now moving on to cardiomyopathy. So in the case of cardiomyopathy, this is where you have, the next kind of cardiomyopathy is hypertrophic cardiomyopathy. So with hypertrophic cardiomyopathy, essentially, usually it's the left ventricle that is growing too much and becomes hypertrophied. So the muscles in there get huge. This can cause from usually an autosomal dominant gene mutation, which results in the sarcomere proteins becoming mutated, essentially. So you can look up all the details with the muscles, the sarcomeres. They just changed the name in the heart. So instead of the endoplasmic reticulum, it's the sarcoplasmic reticulum, and then they have the sarcomeres. The heart is sarco for some reason. So in the case of this, it's going to decrease cardiac output. Anytime you have hypertrophy of the heart, so I'll just put it this way. So here is, say this is the ventricle like this. Let's see if I get it straight on. There's the ventricle. And when it gets hypertrophied, it gets thicker. Look what happens to the space in the middle. See, there's lots of space. It gets thicker. Now there's not very much space in there anymore. So what's that going to do to the cardiac output? Well, if there's not much space in there, even though it's a bigger muscle, it can't push out as much blood. So that decreases cardiac output. Also, it can result in ventricular arrhythmias. I didn't mention this over here too, but this also has arrhythmias. Inside the heart, you have this whole conduction system. It looks something like this. So I'll draw a heart more anatomic. That's the aorta coming off. Superior and inferior vena caves. So you have up here, you've got the different nodes here. You have the SA node, the AV node comes down here. You've got the the bundle of His, and then you've got these fibers coming out, the Purkinje fibers and everything. So if you stretch this whole thing out, then the conduction system of the heart gets stretched out, and the wiring gets a little weird when it gets stretched out. It doesn't quite conduct properly, and that's what causes an arrhythmia. Things don't fire at the same time when they should be firing because things are getting stretched out and weird. So in the case of hypertrophic cardiomyopathy, where you get left ventricular hypertrophy, it stretches out the conduction system of the heart, and it can cause some arrhythmias. Some of these arrhythmias can also result in sudden death. Apparently, with athletes, a lot of times they'll be going out, and then all of a sudden the athlete drops down dead. It's because maybe one of these arrhythmias occurred. Also, they can get syncope with exercise, and essentially, sometimes what will happen is that the septum, which is the space kind of between, so like if you're the atria and the ventricles, and you're the septum is like the space in between, and sometimes the septum can get involved, I guess, and it can almost act like a little bit like a stenosis, and that stenosis can kind of prevent the blood from going out as easily, and when that happens, then it can cause some syncope when exercise. And if you were to do a biopsy and look at the tissue of the heart, you would see it would be described as myofiber hypertrophy with disarray. So the myofibers would be bigger, and they're kind of uniform, branching like this. They'd be kind of like all over the place, disarray. All right, now we're talking about restrictive cardiomyopathy. In the case of restrictive cardiomyopathy, essentially what's happening is that the heart is restricted. So when it goes to move, there's something causing it to not be able to contract or expand properly. So ventricular endomyocardium causes decreased compliance. So endomyocardium, so you have the endocardium and you have the myocardium, so you end up with this endomyocardium, and there's less compliance. So it restricts diastolic filling. So if there's this kind of fibrous band going over between the myocardium and the endocardium, there's like this fibrous tissue in there, and it goes to fill during diastole. Systole it's tightening down, diastole it's filling up, but there's this band that's kind of holding, it's like a rubber band keeping it tight. It can't fill as much. If it can't fill as much, it can't pump as much. So some of the causes of this, it could be amyloid that's building up in there. It could be sarcoidosis, hemochromatosis, endocardial fibroelastosis, which is usually typical in children, or it could be Loeffler syndrome. And this presents with congestive heart failure and sometimes decreased voltage on the EKG. So typically you look on an EKG, you're going to have your P wave, and then you're going to have your Q, R, S, and then it's going to go back here, and then you're going to have a little, your T wave and whatnot. So this usually hits certain voltage, but in the case of this, you're going to look up their EKG, and the voltages are all going to be really weak. They're not going to be very strong. They're going to be really small. And it's one way to kind of tell it, just particularly a diminished QRS amplitude, so it doesn't go as high or low in the QRS complex. Okay, moving on from cardiomyopathy, going on to cardiac tumors. This is straightforward. First of all, we have our myxoma, which is a benign mesenchymal proliferation with gelatinous appearance. On histological examination, there is abundant ground substance, and it's the most common cardiac tumor for adults. And ultimately what happens is there's a pedunculated mass in the left atrium. So if we were to draw here the left atrium, so here's the heart, right atrium, left atrium, you get this kind of pedunculated mass, this little tumor growing off here, and it can cause syncope from obstruction of the mitral valve. So here's the mitral valve here, and this thing can block it right there. And if it blocks it, this pedunculated mass blocks the mitral valve, that can result in syncope. So next is the rhabdomyoma. So rhabdome is muscle. Rhabdomyoma is benign hamartoma of cardiac muscle. Most common primary cardiac tumor in children, associated with tuberous sclerosis. That's apparently high yield to know that this rhabdomyoma is associated with tuberous sclerosis, and it usually arises in the ventricles, which makes sense. If it's a muscle tumor, Is there more muscle in the ventricles, or is there more muscle in the atria? More muscle in the ventricles. So what, just probability-wise, if it's going to happen in muscle, it's going to happen where there's most likely more muscle. So next, just a little discussion about metastases. This is more common than primary tumors. So it's more common for something to metastasize to the heart than it is for a tumor to start out in the heart. And often it'll be like breast, cancer, lung cancer, melanoma, lymphoma, and it usually ends up getting stuck in the pericardium. It causes pericardial effusion. And that is the end.